Okay, Ben is about to join us from New York City, the hot spot. Hello,
Hey.
Ben.
Hey, Dad.
Oh, good. You have earbuds in.
Yeah.
All right, good. Well, let's see. What are we going to do today? We're going to talk about being on the front line in New York and COVID-19 and life in general and just whatever. Anyone wants to ask any questions or talk about anything, feel free to write into us. So, Ben, why don't you start by introducing yourself? Or maybe you introduce yourself first.
I'm Ben Levins. I'm your son. I'm a third-year orthopedic surgery resident at Montefiore and Jacobi Medical Center in Bronx, New York.
And what have you been doing? What's been happening in terms of the COVID-19 situation at Montefiore?
So probably about 5 weeks ago, I was on an orthopedic service I was on an oncology service, and then we got wind that there may be cancellation of surgeries, and there may be moving towards, converting to a fully COVID hospital. And at that point, we didn't really know or appreciate it at all. That, we knew that there was a lot of disease going on in Italy and in Iran and China, obviously, but we didn't really know the scope of it and what was happening. So at that time, they told us we were going to be on this schedule where we were working, partially orthopedics, and then they were sending people home so that we could really just recover or just prevent, herd immunity so people aren't all getting infected by it if this disease comes in rampant. And then really it's crazy how things have changed, because now here we are 5 weeks later, and orthopedics is basically, a skeleton crew, no pun intended, that most of the field is we're only doing emergency-based surgeries, and they've basically pulled first, second, and third-year residents, myself included, to do medicine service. So at Montefiore Medical Center, there's a couple different hospitals, and at all the hospitals, there's obviously COVID units. Most of the hospitals, I would say probably 95% of the hospitals are completely COVID. So they need coverage, and it's mostly run by the medicine services. But in order to facilitate, as much coverage as possible, they've had us come in and take on the role of being medicine residents in this time of tragedy and emergency.
Exactly. Is it happening? I know Montefiore has a very large, a lot of residency programs. So is it happening with other residency departments besides ortho?
Yeah, it seems like a lot of different fields are being pulled. Our orthopedics encompasses, podiatry as well, and we can see that a lot of the podiatry residents have been pulled. We also, when I was in the on the medicine service, there was another resident from psychiatry, from pain management, from primary care. So they're really pulling from a lot of things. I think it's really only emergency-based fields that are staying. General surgery, trauma, things that, are inevitable and will happen. A lot of those residents, have the ability to stay, but things like ophthalmology, dermatology, orthopedics, and they, in some sense of the term, are all being pulled. So
for sure.
There was definitely, there's obviously a huge need, and we go and it's important that we're there. So
for sure.
Yeah.
Well, we're very proud of you, and we're very proud of all the frontline people. And why don't you just tell us about? I think you spent a full week on the medical service, right? Just recently.
Yeah. So
what happened when you get to the hospital? What do you have to do when you get there in the morning?
So last week I was at Wakefield Hospital, which is one of the smaller hospitals, taking care of the COVID service. There's about 200 COVID patients at that time at the hospital. So every morning, I know everyone's worried about the PPE and the ventilators and things like that. So in terms of PPE, fortunately, every day that we got there, they gave us a new N95 mask and a surgical mask that you're supposed to wear over the N95 mask. So the N95 mask covers about 95% of, that's why it's called that, for protecting against airborne disease. So the surgical mask we wear over it is supposed to help us, if they're exposed, if someone coughs into your face or something like that, you can just change the surgical mask overlying it. So they give you one of those, and there's, a good amount from what I saw of surgical mask available on each floor. They also give you a face shield, which you wear once a day. And then you go up to your floor. They also offered us scrubs that you could wear and just, dispose of at the end of the day, like you did your N95 mask. And then in terms of the gowns, the main PPE that people were worried about, there was, adequate amounts on the floor. They would expect us to wear it between floors. So you would wear it and, go from room to room, which normally it's not the case. I mean, most of the time in, normal situations, if there's someone who's on contact isolation, you would wear a gown, you'd go into the room, you'd examine them or do whatever you need to do. And then when you leave, you would just take the gown off and immediately throw it away with your gloves. But they kind of expect you to continue to wear those gowns in order to preserve the PPE. So It's not really the normal, but it was, in order to do that, there was, enough to go around, which was good. There was no there was no point last week when I needed to go into a room without, adequate PPE, which was good.
That's really good to hear. And the floor that you were on was not an ICU, but not a regular floor, sort of an in-between type of.
No, it's a general medicine floor, but it was only COVID patients. There was only, in our hospital, there was only one floor, or half a floor, that was non-COVID patients. And even those, I mean, we had a patient that came to our floor that they thought had COVID that tested negative. And then we sent them up to another floor, but, they were in a room exposed to a COVID patient. So the chances of everyone on that floor not having COVID is very low. But They tried to keep it, as separate as they could and isolate, and in order to, limit the exposure to people that do have it that are high risk.
Right. There are people that have just joined recently. So Ben, just again, I know who you are, but just once again, maybe introduce yourself and where you're at again.
So I'm Ben Levins. I'm a third-year orthopedic surgery resident at Montefiore Medical Center and Jacobi Medical Center in the Bronx. Right now, it's considered the hot zone of COVID, and unfortunately, the Bronx is the highest death rate per capita of coronavirus-related patients. So
interesting. Is that amongst the other city hospitals in New York too?
Yeah, I think it's just as a borough, it's unfortunately the case. But I think it's because even before this, there's, we're of, I think, 62 counties in New York. We're around the bottom, dead last in terms of, health and safety in the Bronx. So there's, already, we're seeing the risk factors in these people that get the worst problems are ones that have, hypertension, respiratory issues, and cardiovascular disease. And a lot of our patients at baseline have that, high BMI. So
there's been a lot of discussion about that nationally. The healthcare crisis that we've always had with every type of healthcare situation, and this just magnifies it because of socioeconomic issues, access issues to healthcare, and so many in the Black community and lower socioeconomic communities, especially in cities, are overly affected, disproportionately affected, which is really sad. Someday, when we all come out of this thing, hopefully we can do something to fix healthcare inequities and access and that kind of thing.
Yeah, there are a lot of issues that need to be, dealt with after this. One is, affordable healthcare for people, or universal healthcare, and then, even things in employment, paid sick leave, and healthcare for providers, people that are now being furloughed, and all these jobs that are being lost in unemployment. There's just a lot of issues that this is really bringing to light. So it'll be important. Hopefully, we can do something about it.
Absolutely. So as far as medicines and everything, people always want to know what works, what doesn't work.
Yeah.
Were there certain protocols or what you guys were treating patients with in the hospital?
Yeah. So it's interesting because obviously this is the first time dealing with this kind of virus. Obviously, there's been viruses over the course of time that we've dealt with, and most of the time when people have the flu or the common colds, more recently Tamiflu, but it's always been symptomatic treatment, which is the main goal for us and our main form of treatment. But in time with these studies, mostly coming out of China and now out of other places, we're moving on. We're seeing there are other medications that are anti-inflammatory and controlling the inflammatory response. So hydroxychloroquine is one that has been talked about a lot, as well as azithromycin. So both of those are pretty popular, and the rationale is that in vitro studies they found that it controls or it reduces the amount of viral load, but there's only few studies so far that came out that it shows that it works in people, and one of them was a small French study, and the results of that were promising, but it wasn't a very large population. And then they actually had a similar study in China that showed the opposite. So we're using it, and we're using with some discretion because it's obviously not the healthiest drug. There are very significant side effects involved with it. So if someone has, at risk of something in their EKG, or they have liver issues, we'll limit our use of that, because it can cause cardiac arrhythmias, it can cause liver dysfunction. So the people that we have given it to, which is a majority of the patients that come into our hospital, they've predominantly improved. So we don't know if they're improving because it's just supportive care and it's just time, or the drug itself is actually working. So
Absolutely.
It's hard to tell. And then the other things we're doing more recently, as of even last week, we started adding steroids to the mix, which is counterintuitive. Most people think steroids wouldn't work, and most people take steroids to reduce their immune system, but the immune response that we're seeing from this virus is actually the worst part, and that's why the steroids are helping. And just anecdotally, from another physician who was working 2 weeks ago, and then she took over again when I was here. She was the attending that we were working with. She just said that in the time that she was there 2 weeks ago, when they weren't using steroids, compared to now, the patient outcomes seem to be much more promising. Most people were progressing towards improvement, as opposed to deconditioning and needing ventilators or ICU treatment. So
that's really interesting. That whole steroid thing is so interesting, because as you know, and I know, or think we know, that people on chronic steroid suppression can be more vulnerable to infections, of course, because their immunity theoretically is down. However, what happens, I guess, with this virus in certain people, which they talk about, perhaps young people, like how could this happen to a young person? And so the two factors I've heard about is how a young person can get it is either they get a really big exposure, like a big viral load, and or they have some sort of a baseline hyperimmune or very immune, sort of revved up immunity that they didn't know about, which is good in general. But the outpouring of your immune response is what then floods the lungs and gets the whole ARDS thing, respiratory failure. So that's where I think the steroids seem to really help, which, you're not really thinking about the long-term effects of steroids. You just want to keep the person alive. And get them off the steroids, and that's fine. So it's an interesting.
We're doing pretty high dose at a short period of time, like 5 days. So the long-term side effects of those steroids aren't as as worrisome. And we'll see in terms of other drugs, hydroxychloroquine, what the long-term effects of them. And we're also doing some studies now on other drugs, retrovirals, a lot of monoclonal antibodies type
treatments,
drugs. Yeah, there's a bunch of different ones we're using, but they're in very specific situations. We didn't use them in ours, but they're available, and they're starting to do research at Montefiore and elsewhere regarding it. So
I heard about just recently. Talk about like optimistic things. You guys on the front lines are definitely vulnerable, but a doctor, it was just in the news yesterday, is a doctor in Seattle, one of the first ones that was on the front lines, and really badly sick and in the ICU, and really like on life support. They ended up doing that ECMO thing, which I know we've talked about before, and then they also ended up giving him one of those monoclonal antibodies, Tagresso, I think, something like that, which theoretically it does something to the receptors that prevents the virus from getting into the cell. So it's really very, very fascinating stuff going on.
One of the things, sorry, that I see people are asking questions now.
Go ahead. Yeah.
One of them was about the anti-inflammatory, like Advil.
Okay.
So it's a good question. A lot of people were worried about that. It came out initially in a French study that anti-inflammatories like ibuprofen, Advil did increase people's risk of COVID-related illness and severity, but the WHO actually seems to have debunked that, and now they're saying that it can be used. The risk that initially was there is not there anymore, but they're saying for controlling fevers, acetaminophen and Tylenol is a better option. But if you have someone who has chronic pain or something where they need anti-inflammatories, I think it's reasonable to use those. But if you're having, if you're having any COVID-related illness, I guess just if you can avoid it, you might as well, given that, in one study it did prove it, but at the same time, it's hard to trust one study if it's a small sample size.
So let me ask you a question, just getting away from the medical part, because I know I'm a plastic surgeon, you're an orthopedic surgeon. We know very little about virology, but we are doctors, so we're trying to read up and know as much as possible. But tell me about the human side. Everyone talks about how sad it is because needing to keep people restricted from their families, and what happens with the patients on your ward. How did that work out?
Yeah, no, that's definitely the darkest side of this, is that it's very isolating, and a lot of our patients come in and they have no connection to their families. Some of them, like, they have cell phones and they can communicate, but a lot of them are older and they have no way to communicate. So the families are relying on us. They're just calling us, and we can give them as best updates as we can, but it's very difficult to give them a prognosis because you don't really know. I mean, some of them, you talk to the family and you say, hey, they're doing fine. They're breathing with a nasal cannula, just like the normal tube in your nose you imagine when you see people in the hospital. And then a couple hours later, they could, rapidly crash. And then by the time you update the family again, it's like, hey, sorry, we had to intubate this person. So yeah, it's very, very morbid. The hospital is offering, they've just adjusted their setting or their protocols in terms of letting people in for if someone's, delivering a baby or if someone's at end of life. They are allowing family members to come, but it's at your own risk. I mean, you're coming into a hospital potentially without symptoms and being very highly exposed to the virus. Right. I think it's it's dangerous. It's a difficult answer. And the thing that sucks is we don't deal with as much thankfully in orthopedics, but I had to deal with a lot last week was calling families and determining code status. It's most people when they come to the hospital, if they crash and they want all the measures to be taken to save their life, but at the end of life, the ability to save people is, sometimes they're like a very poor prognosis, and it's so morbid that we have to speak to the families about. You think it's reasonable to switch them to what we call DNR, DNI, so do not intubate, do not resuscitate. So someone's coming in, an older patient who they can't see their family, they can't talk to them, and we have to basically ask these families who aren't seeing their family member, what do you think? Are you willing to switch this so that if something happens, this patient, you may never see them again. So it's sad, and you try to add some humility into it and speak to these patients, but they really want to limit your exposure to them. You only go in and talk to them briefly, in the morning and pre-rounds, and then during rounds just to say hi and see how they're feeling. But the longer you're in the room, the more you're being exposed and the more you're exposing others. So you really have to limit your, time in there. So you can't really have the necessary conversations that you need to have with these people. A lot of times, some of them they're calling into the room and having the patient answer the phone, and then they're talking over the phone. But it's really, when you're having a difficult conversation like that, you'd obviously prefer to do that, talking to them in person. But It made it very difficult with the virus to do that.
Sure. So let's talk a little optimistically. It looks like from Governor Cuomo's conference, I know several days ago they were talking about things maybe approaching a plateau, Still lots of deaths because it's lagging and that kind of thing. But the latest is, I think that at least in New York, it's looking like the plateau has happened and perhaps on the downslide a little bit.
So we're all about flattening the curve and finding the plateau and everything that Dr. Fauci always talks about. But we get in-hospital data that our graphs show that we peaked through the hospital system at about like 1,100 total patients, and it seems like now that number plateaued over the last couple of days and is finally trending down. It's about 100 less now. So
excellent.
Hopefully trending. I mean, it's hard to predict. You never know. It could spike again. There could be changes, but it seems like overall as a trend, there was an exponential growth initially. It plateaued, and now it's heading towards, downtrending. In terms of what we can do for long term, I know people are asking about the NFL and about elective surgery in the future. I don't know the answers to those questions. It's really going to be, it's hard to predict. But Dr. Fauci was just saying recently that he thinks that sporting events can return at some point, but it's going to be without any fans involved. We're really going to have to continue this social isolation. And could you imagine going to a stadium where you have to stay 6 feet away from people when in reality, when you're waiting in line for the bathroom, there's about 1,000 people there. So
that'd be difficult.
So a lot of this stuff is going to change potentially for a long time, and it's hard to tell when it'll return to normal. But our initial thoughts, one of our chairman was saying that they're hoping that maybe by mid-May we can start surgery again. But the question is, outpatient surgery, if you're operating on someone and they go home that day, it's fine. They're not really exposed. But if you're admitting someone to the hospital, then, and someone has COVID next to them, it's a difficult choice.
So I think that's a really good question. It's a really big point, and that's what's happening now is all this discussion about when, and everyone would be, so happy to think that it's the middle of April. Oh boy, May 1st, we'll open up. What's clearly not going to happen that way, and it's got to be very careful, very judicious, a lot of planning, and a lot of persistent, continued precautions. I mean, less volume of patients, less, more distance with patients, using masks and all the, protection. And then as we're starting to ramp up, hopefully more and more testing, and then getting closer to a vaccine. So, I mean, literally, it'll be months and months and months. But it's interesting. I mean, Cuomo was talking about trying to, it's very objective, but it's, getting down to the nitty gritty details is going to be difficult to see which are the businesses. Obviously, your business and the healthcare business is very essential, police, firefighters, et cetera, transportation. And so what's going to be the next level down, if not as highly essential, but what can open up that's still quite essential, but yet a low risk of getting something. So if you're in a business where you can distance well and you only have a few workers and you can be careful, then you have less of a chance of spreading it. But if it's a business with a whole bunch of workers in it, then how are you going to control it? So it's going to be a real challenge.
Yeah, and wearing a mask, I think, is important. Absolutely. Avoiding touching your face. They say the T-zone, so your eyes, nose, mouth. It's very difficult, I'm sure, during this video. You and I have probably touched our face a lot.
I noticed you did that. Actually,
yeah, I mean, some people are asking just about some basic questions. So just thinking about
go ahead. Yeah,
going.
I see that Ben is a hero. What else?
Yeah, people are very excited. So I thought we'd just go over the basic stuff. Our hospital sends out, but just important for people to know. The main symptoms people have: fever is the most common, cough, often non-productive, shortness of breath, fatigue, poor appetite. There's a lot of talk about the GI symptoms, which aren't as common, but if you do have GI symptoms, often diarrhea, nausea, decreased appetite, headache. Comparing this to the common colds, things like runny nose and nasal congestion, which you often have with the common cold, are pretty rare with this. So if you're worried about whether you have COVID or not, if you've been exposed to someone, chances are you likely do. But if you're trying to differentiate between just a common cold and COVID, coronavirus, or the flu, something like rhinorrhea or runny nose and sore throat or nasal congestion, are more likely with the common cold and less likely with COVID. So those things are important. And then from what we've seen in our hospital, about 80% of people that are infected have just mild symptoms, things that don't require hospital admission, that can just send them home. And the remaining 20% need that hospital setting. And of those 20%, about 5% need ICU level care. And like I said before, the risk factors we worry about are hypertension, prior respiratory disease, cardiovascular disease, smoking history, kidney disease. A lot of the basic comorbidities that a lot of people have, especially in the Bronx, are things that we worry about. And the technical stuff about why these happen is, much over our pay grade and our knowledge, but these are what we found. And then for people who were exposed, usually the incubation period, so the chances of you developing symptoms, is between 2 and 14 days, which is pretty long compared to other ones. But the average is about 5 days. And then from one of the studies I saw, which is based on literature reviews of overall symptoms, they say 95% of people have symptoms within 10 days. So I wouldn't say you should go outside in 10 days. You should probably wait the full 14 if you've been exposed. But chances are, if after 10 days, if you don't have symptoms, you likely don't have it. So that part is reassuring.
Can I just interject for 1 second?
Yeah.
I'll raise my You had early on, a few weeks ago, one of the co-residents that you had. So you had mentioned to me that a number of them did or either tested positive or had positive, but you had close contact with one of your co-residents that had tested positive, and for that reason, you were quarantined. You had basically stayed in your apartment for a while. It was almost 2 weeks, I think. You didn't end up getting any symptoms, I think, right? And
no, correct. I didn't have any symptoms, which is, they're seeing that's, a group of people are not having any symptoms, and it's hard to judge how long you're supposed to isolate if you feel totally fine. But from what we're telling people, when they leave the hospital, they stay, they should continue isolation for, this is based on the Department of Health of New York. It's, you can look at your state's individual one, or it's pretty similar to what the CDC is saying as well. But if you've been afebrile for at least 72 hours without needing any, Tylenol or anything to break your fever, and at least 7 days since the onset of your symptoms, so when your symptoms first started and your respiratory symptoms are improving, all this stuff means that you can stop with the isolation. But if you're still having any symptoms or fever, you should remain isolated.
Do you know of any of your residents that have had that have had any like severe symptoms at all? Any of your co-residents that might have?
None of, I don't think so. I don't think any of the residents have had severe symptoms. A lot of them have had that mild classification where people, the severity really varies. Some people say it feels like the worst, flu or virus they've ever had. They're just debilitated, really body aches and fevers and just don't feel like yourself. Right. Some people say it's as much as just a cough or a headache, and they test positive. The other thing we're finding that's interesting is that there's a huge false negative rate, meaning that people test negative, but they actually have it. The numbers I saw from some of the data is quoted between 66 and 80% sensitivity, meaning that there's almost 30% of people who test negative may still have the disease. So
do you know I'm not sure what that test versus, I mean, basically in the hospital they have a certain test, and then
the swab,
Abbott one, and I don't know, it's a whole bunch of different tests, but do you know which test they use in the hospital? We use
what's called a PCR test. So it's the nasal swab. They put one of those really long swabs all the way, basically to tickle your brain, and then we send it to the lab. It's pretty quick. It depends on the time, but it seems like right now in the hospital, our hospital has producing that result pretty quickly within 12 hours. But some of the tests, testing centers like Quest, places you send it out, take much longer, and they're having a lot of issues with that. So it's hard to rely on those tests.
That's clearly a problem, because the testing, I mean, that's going to be one of the key factors to be able to, see about the whole opening up and continuing to surveillance and all that.
Yeah, and people are asking about antibody tests. We don't have them at our hospital. I know they're, up and coming, and the future of that is going to be really important to see who is exposed, who needs to continue to wear the PPE versus, doing herd immunity and getting people who need it to get, get them affected. But we don't have that available at our hospital, and I don't know, the prelim ones seems like there's not enough data on them yet, but I imagine in the upcoming months we're going to have this stuff pretty soon.
Exactly, that's the optimistic thing. Okay, so should I report something that I found out from a
Sure.
Just as far as precautions, I mean, many people are wearing masks outside now. Many of the public, homemade masks, cloth masks, etc., gloves, alcohol wipes. Keeping packaging outside. A friend of mine is an infectious disease doctor here in Florida, and he said he sees about 20 COVID patients daily. And he put on Facebook, so it must be true, using Peridex, which is chlorhexidine gluconate, which is a skin prep for surgery. It's a very good skin prep, alcohol-based. The Peridex is a much lower concentration. It's used for gingivitis, for dental care. And so his recommendation is it's 0.12%, and it is by prescription. But what you can do is, because he was talking about how the virus, settles on your mucosa, the nasal mucosa, and it takes about 24 hours for it to sort of get set up and start to replicate. So if you've been out or do it just twice a day, just take a little Q-tip. What he's been advising is, and just sort of do your own nasal swab with the Q-tip of Peridex, and then gargle and rinse your mouth with it. And, I don't know, we've tried it a couple times and it doesn't taste so bad. So we'll see if that's helpful. But, just another one of these little tips.
No, I think those are good, especially if you don't have a mask and you go in somewhere where there's, high risk of exposure, like a grocery store or something like that. But I think if you're wearing a mask, you're pretty safe. I know the ophthalmologists are recommending not using contacts if you're in high exposed areas, because that's another mucosa that you can be exposing. So people recommend wearing glasses. So I think there's a lot of that stuff. And obviously, the more protective and precautious you are, the more you wipe down everything you do. And, every time you go outside, you take all those clothes off and you wash them immediately. You're going to avoid your risk as best you can. But it seems like even if you are slightly less cautious, you're still, you still have a pretty good chance of avoiding the virus as long as you wear a mask or cover your face when you're around people, and avoiding just general, social isolation and all that important stuff.
So the thing about that is, of course, it's very situational. That's the discussion about the different states as far as population density. I mean, it's clear New York is a huge population density, and a lot of international travelers, and the reason why it started there. But I was asking you, when you went home, do you go outside? Here in Florida, we go outside and we can be distant very easily. In New York, it's not easy to be distant, but you were saying how you felt the responsibility to not go out and potentially expose other people and whatnot. So you mentioned that the other day, that you did get a chance your girlfriend was kind of cooped up, and you said let's go outside and carefully distance and walk along the river. So what's that experience like? Is it? I mean, does it seem like there are a lot of people out, not many people out?
Yeah, I mean, I tried to treat it like only doing it seldom because I kind of feel guilty. I think if everyone's cooped up in their apartments and everyone is, living in these tight, quarters, and especially in New York, and everyone wants to go outside. And if every person said they could go outside every day, then it would be packed out there. So if you use it as, kind of, rewarding yourself once a week to go out there and walk, I think it's reasonable. We went to the East River yesterday. It seemed like there was, enough space for you to be about 6 feet apart from people, but there still are a lot of people outside. I think it's important to stay home as much as you can. And if you are going to go outside, if you have high risk, if you have any risk factors that you're concerned about or immunocompromised, you either shouldn't go out, but if you need to, you should wear a mask at all times. If you're someone who's young and healthy and you want to go for a run for 30 minutes, I think it's reasonable to do that. But I mean, everything is with discretion. I think it's, you have to be cognizant that every time you go outside, you could expose someone else. And, I just didn't want that on my conscience, so I felt bad.
Tell us a little bit about about all the love for the healthcare workers that's happening in New York. 7 p.m. occurrence. What's that all about?
Yeah, so there's definitely been a lot of, positive things that come out of this. A lot of appreciation for healthcare workers, which is nice. At 7 o'clock every day in New York, there's just an uproar of claps that you can hear, all around the city. People just, appreciating us and cheering for the doctors and healthcare workers, all the nurses, and just essential staff that's stuck at the hospital working. So that's a really good feeling, and you can hear it. And sometimes people play music, so it's really nice. There's also been huge donations to the hospital. I think the entire week I was there, I didn't spend $1 because there was always donated food from the orthopedic department, but also from other, local restaurants just delivered food for us. Excellent. And then the hospital itself offered free food. So there's, really good, there's really positive things coming out of this. And just, it's nice to see the resiliency of the hospital, that we kind of just dropped everything and converted into what is, an emergency setting hospital. And things are still, despite all this, things are still flowing relatively smoothly. We are transitioning well. People are coming in, people like me who haven't done any medicine-related things in years, coming in and, taking on patients. And I felt like there was a lot of support even from, the medicine doctors and the residents. Everyone's really helping each other out because it's one goal, which is getting everyone out of the hospital.
Absolutely. You're all in it together.
Yeah.
Absolutely. Tell us about when you finished your your week, the last shift you left, and it was particularly emotional for you, or you had, besides all the New Yorkers clapping and honking and whatever, you had some other.
Yeah, so it was really cool. We left the last day, and there were a bunch of fire trucks outside, and on top of all the fire trucks were all the firemen clapping and sounding the alarms and everything. So it's just they're especially essential at all times. So for them to appreciate us is just it's really cool. And I mean, for they're going out and putting their lives at risk at all times, and for them to appreciate us is really nice. And when I was walking in the other day at 7 o'clock when I finished work, a police officer drove by and held a sign that says "We appreciate you." So there's definitely a lot of cool stuff happening. And you try to think about it on the positive side. The positives are, it seems like the numbers are downtrending. During the week that I was in the hospital, it seemed like overall people were improving more so than they were doing worse. And, just the general charity and appreciation from everyone is really nice. So
great.
Thank you for what I've experienced, but it definitely helps, which is nice.
Perfect. Well, Ben, we want to thank you so much for what you're doing, and you are a hero. And unless there's anything else like major to talk about now, we could probably wrap things up because we probably.
It seems like a lot of the questions are not healthcare relevant.
Well, I saw someone say something about like this male pattern baldness caused by COVID. I have a feeling some of your friends are pimping you here, whatever.
Yeah.
But it's okay. Good.
Yeah.
You got to laugh. That's what you got.
No, I appreciate everyone listening to this, and I know neither of us are experts in the field, but. We're just trying to do our best to inform everyone the important things, which are stay home. If you have symptoms, don't rush to the emergency room. If you feel like you're short of breath or you can't breathe, it's important to go to call your doctor, go to the emergency department, but really just avoid exposure of others.
Exactly.
Those are the important things.
Exactly. Okay, good. So should we wrap it up?
Sure.
Okay,
close
good.
out.
Okay, well, love you. Take
Love you
care.
too.
And have a great day. And say goodbye to everyone. Goodbye, everyone. We'll see you
Bye,
soon.
everyone.
All right, take care. Bye-bye.
Thanks.
Bye. And now, you sure you want to end your live video? And now.